Welcome to Clinical Conversations 101st podcast. It comes to you from Journal Watch, your guide to the most important current clinical literature for almost 25 years. Go to the website at jwatch.org. I'm Joe Elia. It's September 17th, 2010. We take as our topic this week chondroitin, glucosamine, and their effect, if any, on osteoarthritis. A new meta-analysis carefully dissects the results so far, and we travel to Bern, at least telephonically, to converse with two of the analysts. Here we go. This week, BMJ published a meta-analysis of 10 trials encompassing almost 4,000 patients. The studies explored the effect of chondroitin, glucosamine, or both, primarily on the pain scores of osteoarthritis of the knee or hip. All were placebo-controlled. In the pooled results, although both chondroitin and glucosamine showed statistically significant results in reducing pain at some time points, the analysts caution that statistical significance should not be confused with clinical relevance. Looked at from that standpoint, the treatment regimens have nothing to offer in the relief of pain. Two of the authors have agreed to discuss their work with us. Professor Peter Juni and Sven Trella are both in the Institute of Social and Preventive Medicine at the University of Bern. They are also in the Clinical Trials Unit at Bern University Hospital, which Professor Juni co-directs, and where Dr. Trella is a senior research fellow. Welcome to both of you. Professor Juni, what got you interested in this question? There have been other meta-analyses made. Did you consider them not definitive?
Well, we were involved also in other meta-analysis covering the topic, and together with other groups, we believe that we still needed more definite answers. Also, addressing, questions of a time-depending effect, asking whether there might be an effect, perhaps to be observed at 3 to 6 months or so, but not at 24 months, etc. And the analysis we did used novel statistical methods to statistically summarize all the large-scale, high-quality trials, also addressing the problem of time dependence.
Now, you said that they are novel statistical methods? Is that right?
Yes.
Okay, so I noticed that the meta-analysis seemed very carefully done, but it seemed complicated in its approach. And could you, Sven Trella, can you talk about how this approach differed from other approaches?
In a standard meta-analysis, basically what you are doing is pooling direct comparisons of interventions together, whereas in this network meta-analysis we also pool indirect evidence. For example, if you have two comparisons, one's comparing chondroitin with glucosamine, and one is comparing chondroitin with the combination of these two, you can get indirect evidence on the comparison of glucosamine and the combination, because these two comparisons are connected, and this network meta-analysis allows basically for the combination and the pooling of all these connected comparisons.
I see.
And provides them more power usually.
You would only use that if there were more than one treatment under or more than one drug. I mean, you wouldn't use it, say,
Sure.
if you were doing, say, chondroitin versus placebo.
You can only use it if you have at least three interventions, and you want to basically pool and look at the whole evidence on these 3 interventions, or in our case, it's basically 4 interventions.
Okay, so enough statistics. We'll focus a bit on the clinical significance, and your analysis steers the reader toward the clinical significance of those measured differences, and you warn in your paper against confusing statistical significance with clinical effect. Sven, can you talk a little bit about that?
Sure. Especially in these studies, in these relatively large studies, we can easily detect even minute effects because the sample sizes were relatively large for measuring pain effects on pain, basically. But these minute effects do not necessarily translate into any benefit for the patient because they are so small, and you can even detect near null effects if you are large enough. And we have 4,000 patients, more or less, in the analysis. So it's in this analysis, it's mainly about clinical relevance and not about the statistical significance, actually.
Sorry, Peter Uni speaking. So basically, the point is probably for these comparisons to have adequate statistical precision, we would have needed something like 600 to 900 patients overall. And here we have about 3 to 4 times as many patients, and as Sven correctly indicates, and the statistician may be able to detect something, but the patient will not. The patient will not find any difference. Even so, statistically, there might be still a significant p-value, which is basically relevant.
I see. So, nicely put. So, the statistician is able to discern the difference, but the patient is still in pain and can't really express a difference, a benefit of treatment. You noticed that the industry-sponsored trials in your meta-analysis tended to find treatment benefits, whereas the independent trials did not. Was that a surprise?
Okay. Well, it's Peter speaking. Well, it's not entirely a surprise. We are well aware, all of us are well aware, that industry-funded trials tend to show more beneficial results as compared to industry-independent trials, which probably is a combination of selective reporting of outcomes and probably also of some issues just related to the methodological quality of the studies.
Sven, you have anything to add?
I think what is important is not only to focus on the p-value on the industry funding studies or not, but also looking at the other analysis, because we actually tried to explore the reasons why this might be, and we also looked at the usual quality criteria for the trials, but also for additional ones that never had been looked before, like the quality control of preparations, which the industry usually mentioned as one point that is that's an advantage in the industry trials, but we didn't find any differences in the trials that had quality control of preparations or not, or the type of glucosamine, for example, is also often mentioned by industry to have an influence, but we didn't find anything there. So we actually don't know the reasons, the real reasons behind this effect, but it's not the ones industry usually brings forward.
Okay.
I'd say.
You mentioned at the end of your paper a trial, an ongoing trial that we won't have the results of until maybe the end of next year. And you think that it's so well designed that it may finally irrefutably answer the question. Are you involved in that trial at all?
No, we're not, Peter speaking. It's an industry-independent trial we're not involved with. We know the trial lists, however, and basically it could be, if there are, again, negative results, the last nail in the coffin of these supplements.
Okay, so from the standpoint of a clinician seeing patients next week, what do you recommend that they say to their osteoarthritis patients next week that maybe they weren't able to say last week before they read your paper? I'll ask Peter.
I think there are two aspects. The bad news are we don't have evidence that these food supplements work. The good news are we don't have evidence that these food supplements are harmful. The conclusion for our patients must be, well, first of all, if they entirely believe that these preparations are beneficial for them and they're ready to pay for these preparations themselves, probably a lot of our colleagues would not personally argue against them continuing these preparations. But I also think we should be upfront with our patients, especially if they're still treatment naive, and tell them that there is no evidence to suggest that these preparations actually work, even so they're marketed as if they worked appropriately against pain.
I want to thank you, Professor Uni and Dr. Trella, for taking the time to discuss your results and, at least in the interim, settling this question.
Thank you.
Thank you.
Here's a quick look at the week's most important clinical news stories. Screening for prostate cancer with PSA testing doesn't confer a mortality benefit, according to a BMJ meta-analysis encompassing almost 400,000 patients. Screening does lead to overdiagnosis, however. Another study used stored blood samples from about 1,200 Swedish men at age 60 in 1981 to look at outcomes in the light of retrospective PSA testing. The researchers find that PSA levels at age 60 correlate closely with the risk for metastatic cancer or death from prostate cancer by age 85. Levels under 1 nanogram per milliliter were associated with a low likelihood, about 0.5%, of suffering prostate cancer metastases. Next, there's apparently a distinct phenotype of chronic obstructive pulmonary disease characterized by frequent exacerbations. Even though greater severity of COPD was itself associated with more frequent exacerbations, the best predictor of these events in a 3-year study was the self-reported presence of an exacerbation in the previous year. An editorialist in the New England Journal of Medicine considers the phenotype clinically important because available treatments can lower the frequency of these exacerbations and may thus affect the outcome of COPD. Finally, a worrisome new resistance factor has found its way to the U.S. and Canada from India, Pakistan, and the UK, where it was first noticed. The factor is called NEJM1, for New Delhi metallo-beta-lactamase, and it seems to have found a home in enterobacteria like E. coli and Klebsiella. Well, that's it for Conversation 101. I'll be back next week. My email address is jelia@jwatch.org. Earlier podcasts are available at podcasts.jwatch.org. Clinical Conversations executive producer is Ador Yano. I'm Joe Elia. Join us next time, and thanks for listening.